with this, it is my pleasure to introduce you to Fabio Candotti, who is the president of the European Society.
Thank you, Clara. Thank you for the hospitality so far. We were just saying that we are all having a great time, great hospitality, great place where we are, great food. So this is happening in the right way. So Clara asked me to give you a presentation on current knowledge of primary immunodeficiencies. The title is vague enough that allows me to do what I want, basically. That's always great. And so there. I'm going to start with this slide. Many of you know, many of you are becoming tired of it, probably. But it just tells you what has been the evolution of the field of primary immunodeficiency over the years. And you can see that the discovery rate has increased dramatically, especially starting from 2010 or so when next generation sequencing has become available. And it has evolved so far that right now, many of the immunological pathways that we know that are so important for the development and function of the immune system have basically been mapped. And as you can see here, all these genes or these components, proteins that are important for the NF-kappa B pathway or for the IL-12 gamma interferon pathway have been identified as being associated with human diseases. And that is basically happening throughout the immune system and throughout many different immunological pathways. And so the status of the field is increasing. And the area of where we operate is increasing more and more. And so you can see the increasing area that from the current knowledge, I'm sure that 10 years from now will have expanded dramatically. But what I'm going to talk to you about today is that the expansion is not only horizontal, I'm going to try to prove to you, but it's also vertical. And I'm going to have to, I'm going to present to you 3 cases that exemplify what I mean here. In the spirit of the summer school, the first case is a clinical case. And it is the story of this woman of 62 years old that comes to the clinic, to the immunology clinic at our hospital, with an infection history of recurrent otitis media tonsillitis in childhood and recurrent bronchiolitis, and also a series of inflammatory dysimmune complications. And they are listed there: hepatitis, optic neuritis, rosacea, ankle arthritis, and tenosynovitis. More recently, she came down with a severe case of diffuse cutaneous T-cell lymphoma, and she has other problems, neurological complications, and even a gallbladder lithiasis. Our colleagues from dermatology sent her to us for immunological evaluation. We did the usual immunological workup that we have heard so much these days. We found a lymphopenia, T and B, and some abnormalities in the cytokine, in the serum cytokines, indicating a little bit of inflammation, most likely. But really, we didn't spend much more time trying to really put all this together with the diagnosis. I don't know if somebody wants to venture one, but for us, we just went straight to the exome. And what we found was this. We found a status of compound heterozygosis for 2 variants in the RAB27A. The adult physician here probably don't know what this is, but it is the RAB27A is the protein associated with glycerol type 2. Again, our pediatrician know this. My colleagues, adults, had to go to Google, and what you find is this picture. So, and you know that, and so this is nothing that looks like a 62-year-old woman with hepatitis. And so looking again through Google, my colleagues found that this is a autosomal recessive disease described by Claude Grisely that is characterized by partial albinism, silvery hair, immunodeficiency, susceptibility to viral and fungal infections, a high risk of HLH, and usually at that early in infancy, unless these patients receive a bone marrow transplantation. So this doesn't really look like the case of our patient. So if we go back here, we found two variants. There. One is frankly pathogenic. The other one is VUS with tendency to pathogenicity. But like this, we don't know if these are in cis on trans. So she might carry two variants on the same chromosome and not presenting the disease, and these variants may not be causing her disease. So when you are in the situations, you try to do some familial segregation. At this age, most likely you don't have the parents available, but we find out that she was born to a consanguineous union. And we were lucky because her mom had produced two sons to another marriage. And we were able to test these two sons, and they both carry only one of the variants, indicating that these two variants don't travel together, and therefore that compound heterozygosity in the patient was in situation of trans, which could then justify a pathogenicity. In fact, if you look at the literature, these two variants have been published in cases of Grisely type 2. And when we call back the lady, she came with longer hairs compared to the first time, and we were able to see this silvery hair of hers that we had not noticed before. And our colleagues in dermatology were able to demonstrate that her hair had problems with pigmentation. So in this case is an atypical case of Grisely type 2 syndrome. And it's not the only one, because two cases have been published that had presented with HLH, so that it is, in our case, is a little different because this lady has managed to stay HLH free until now, and that it really is what is the first comment of my series of comments on the status of the field, that in addition to this ever increasing number of genes that are associated with PIDs, we start to see we have to be ready to finding unpredicted outcomes of known forms of PIDs. The second example I want to pose to you has to do with the IgE syndrome. That is this disease that you all know very well, characterized by infections, abnormal inflammatory responses, eczematous dermatitis, eosinophilia with elevated serum IgE, and connective tissue abnormality that give these patients a peculiar faces, a tendency to easy fractures, retention of deciduous teeth, and aneurysm formation. This disease is caused by a series of different pathogenic variants in different genes. For the majority of cases, is a problem of STAT3 signaling, and it's a problem of STAT3 signaling that is defective and that ends up in a series of complications and mechanistic alterations that explain the polymorphic presentation of the disease. We got involved in this disease through a collaboration with Vivienne Béziat in Paris. that had recently found a new group of, or characterized a new form, a genetic form of the disease caused by the mutations in the GP130 or IL-6 ST component of the IL-6 receptor. There is a dominant form of the disease because when you have this mutated form, in 3 out of 4 combinations, you have a non-functioning receptor. Vivienne had shown a series of cases that had mutations downstream of the JAK1 binding sites, but upstream of the recycling motif, which caused an accumulation of the protein on the membrane that can be used as a diagnostic tool. We had added a case to this series that was located in the most distal portion of the receptor known to date, as you see here, with a NIH score that is high, similarly to all the other NIH scores that have been described before. What was novel in this more recent group of patients characterized by Vivienne and his colleagues was this variability of the score of these 7 patients from 2 different families. They all had the same variant. As you can see here, the score varied from 12 to 37. And if we look at the clinical presentation of these patients, what you can see is that most of them had the typical presentation of the disease with high IgE levels, eosinophilia, upper respiratory tract infections, susceptibility, and the bone phenotypes, scoliosis, and other problems. So this fits with the phenotype of what we know about hyper IgE caused by STAT3 deficiency. But look at this patient. This patient does not have anything, does not have anything but scoliosis and bone fractures. So this is surprising enough and made me conclude that I would never say again, this patient does not look like something with that disease, because clearly you cannot really predict this patient is an hyper IgE patient. So he carries variants in one of the hyper IgE associated genes. So another take-home message is that we continue to see heterogeneity of clinical presentation, even in the same family, even in patients that carry the same genetic variant. The last example that I want to propose to you has to do with the Wiskott-Aldrich syndrome. You all know this disease is a X-linked immunodeficiency characterized by thrombocytopenia, eczema, susceptibility to infection, malignancies, autoimmunity, and is caused by mutation of the gene that encodes for the Wiskott-Aldrich syndrome protein that, as you know, is important for cytoskeleton remodeling and function. The disease is characterized by all kinds of cellular dysfunction due to the problems with cytoskeletal polymerization. Here is just one example of what goes on in a Wiskott cell that, as you see, is very much unable to produce normal size macrovilli. We've seen many of these patients, especially during my stay at the NIH. And if you look at the CBC of these patients, you see what you expect. You see low platelet counts with a low mean platelet volume. But as we continue to see these patients, we continue to accumulate patient cases, we notice something more. we noted that there was a reduced level of hemoglobin associated to this morphology of red blood cells. So for many years, we really attributed this to one of the known complications of Wiskott. So autoimmune hemolytic anemia, as you can see here, is the most common autoimmune complication of the disease. But again, we were really intrigued by this continuous finding in patients that did not have any phenotypical or clinical presentation of hemolytic anemia. So we did some surveying, hematological surveying of these patients. As you can see here, we looked at 25 patients, and in many of them we saw that the hemoglobin was low, not anemia level low, but certainly lower than the normal. The plasma, there was free hemoglobin in the serum in many of these patients, and haptoglobin consumption also was found. And in this series of 25 patients, we were able to demonstrate that in 18 of them, there was some subclinical non-immune mediated hemolysis. So this was interesting, and it was even more interesting when our hepatology colleagues showed us these smears from these patients, and you can see there are all kinds of abnormalities from echinocytes, stomatocytes, cigar cells, bite cells, target cells, and even some South Asian ovalocytes. They are there. So then we asked the question, is it possible that WASP has a role in red membrane integrity? Because we have evidence of hemolysis and we have evidence of this morphology of red blood cells. So the first thing that we did was to look at osmotic fragility, and we didn't find an increased fragility, so that was not the problem. But given that we found as I showed you, the South Asia ovalocytes, and those are caused by mutations on one of the band3 genes that cause problem with rigidity and increased rigidity of the membrane. Then we looked at deformability of the red blood cells from Wiskott patients, and as you can see here, the deformability of these four patients was reduced compared to controls. And again, based on the fact that the South Asian ovalocytes are caused by a problem of ionic exchange, we looked at sodium and potassium content in red blood cells from Wiskott patients. And you can see here there is a significant difference between the sodium and potassium content of WASP patients to control, with a possible potassium leak outside of the membrane that perhaps is contributing to the problem, the red blood cells problems of these patients. We were comforted also by finding similar problems in the mouse model, and therefore this seems to be something that really is caused by an absence of WASP expression. We still don't know exactly how defects of cytoskeleton remodeling can cause this, but hopefully some of our hematology colleagues in the audience can have some ideas for us. So the last comment is that working in the field, offers the possibility of discovering new traits, expanding the known phenotype of PIDs, and obviously is one of the things that keeps us working in the field and keeps us excited about our activity here. So the current knowledge of PIDs, boils down to this stereotypic conclusion that you see almost everywhere where we talk about PIDs. So we truly need to expect the unexpected, and there will be more of this in the future. I'm sure of this. And I'm just to say thank you to all the collaborators that have allowed this work to be done, the observation to be made. And I thank you for your attention.